First of all, I welcome Dr. MC Rajesh to talk on differently abled child for surgery, perioperative concerns, a very interesting topic because it is rarely discussed, and more so, we don't give much attention to needs of differently abled children in our daily practice, though we come across them very frequently. So I know Dr. MC Rajesh can do a wonderful work because I know him personally, is my good friend. He is at present consultant anesthesiologist and academic coordinator at Baby Memorial Hospital, Calicut. He has been serving anesthesiology fraternity in various capacities, including member of editorial board of Indian Journal of Anesthesia. He is associate editor of Kerala ISA Journal, IJ South Supplement Edition, and Baby Memorial Hospital Medical Journal. He has also won COPS Award. He has got number of publications in national and international journals. So you can fathom his depth of knowledge and proficiency in conducting academic programs. So I welcome Dr. MC Rajesh for the deliberations. Before I want to say my greetings to Dr. Baljit Singh and Dr. Sunish and all other dignitaries present here, Jayasri Sood Madam and Muralidhar Sir and everybody. I wish a great discussion here, and over to you, Dr. Rajesh.
Thank you, sir. Thank you, sir, for the nice introduction. And at the outset, thank you, B. Radhakrishnan sir and Sanish for the invitation. And as often highlighted by Radhakrishnan sir and Dr. Sripada, it's not often discussed a topic and neglected one also. So, is my slides visible?
Yes, Dr. Rajesh.
Yeah. Okay. Thank you. So, disclosures, I have no conflict of interest or no financial support. So I'll start my presentation, the case scenario, with this opening remark. I wouldn't change you.
Rajesh, in between, I want to request the audience to post the questions in their chat box so that we can take up them in the end of the session. Sorry to interrupt you.
I will be doing that, sir.
Okay, sir. No problem. No issues. So my opening remark is, I wouldn't change you for the world, but I would change the world for you. This is exactly what is expected by an anesthesiologist when a challenged child, emotionally, physically, or mentally challenged child or disabled child comes to you for anesthesia. You don't have to follow the set protocols, or very often you may not be able to follow the set protocols, and you have to think out of the box and put the patient in a different scenario. So I'll start with the case scenario. This is a 8-year, 23 kg female child. She was posted for micturating cystourethrogram and cystoscopy for recurrent urinary tract infections. She was actually admitted with recurrent fever, shivering, frequency of micturition, and crying while passing urine. Child is having a delayed milestones and diagnosed to have autism spectrum disorder at the age of 4. And there's a history of fits, one single episode at the age of 4. But since then, the child is on Levipol, 250 milligram daily, and syrup Tegretol 1.5 teaspoon twice daily, which comes to around 300 milligrams. Operating for any blood test, further investigations. And the primary caregiver is mother. The child is very attached to the mother, mother is actually a homemaker, and she is always with the child. And the history is that at 32 weeks, it was done as an emergency LSCS for a fetal distress case. And child was admitted in the neonatal intensive care unit for 1 day. And the milestones are delayed and the immunization status was up to date. There is no non-drug allergy or no previous anesthesia exposure or no bleeding episodes, no obvious craniofacial anomalies, There is only one episode of hospitalization in the recent past for similar complaint, and medical records showed autism spectrum disorder level 2. I will come to this, what is autism spectrum disorder level 2 later on in my presentation. So the pre-anesthesia visit, I noted the potential cannulation sites, and the child was noted to be happy with iPad and showing Cartoon Network, and anesthesia procedure explained to the parents and consent taken. I will show the consent forms which we inform the consent forms which we take in our institutions, and child was planned to take as the first case, and OT staff was informed. And history's mother says no, there is no loose teeth, and the external appearance is okay, but the child was not opening the mouth. And post-op isolation area is marked for the child and was shown to the parents. They were comfortable with that. And mother is instructed to have food once the child is taken to the inside the OT, because once the child comes out of the OT, the mother has to be with the child for the rest of the post-operative ICU stay. And the parents is instructed to give clear fluids to child till 6 a.m. and apply amla cream with occlusive dressing, which was instructed to the parents, mother. And my personal preference for all pediatric case, and for this case, was also dexmedetomidine 50 microgram transnasal, which was given at 8 a.m., which comes to around 2 microgram per kilogram body weight. And I had to wait for 30 to 45 minutes. And once the child is sedated, I put the 22G cannula on the right forearm, and fentanyl 25 microgram was given slowly as the child was focusing on the iPad. And once the child went to sleep, she was separated from the mother and shifted to OT, and there was a pulse oximeter probe attached also, and O2 mask. So in the OT, we have deepened with the propofol 50 milligram, and which was mixed with, of course, mixed with the lidocaine, and other monitors, as a standard one monitors, are also attached. Non-invasive blood pressure, ECG, entitled carbon dioxide, SpO2 probes were attached, and child was on till this time spontaneous mask. And after deepening the child, I put the 2 size igel and maintained on oxygen air sevoflurane on spontaneous ventilation. And actually the clinical examination, auscultation was done after that, because till then child was not allowing to touch the body. So the clinical examination was done, blood samples taken for the blood routine examinations, and the surgeon wants the creatinine level also, and the top of doses of propofol was given, and the procedure lasted for only 30 minutes, and the child has an uneventful recovery. Vitals were stable. She was shifted to the post-operative ICU. So this is an uneventful story of a child, a disabled child, coming for cystourethrogram and mixturating cystourethrogram. So what are the challenges? Having discussed about this case, what are the challenges and usual strategies we have to adopt in such a scenario? When we say differently abled children, the usual conditions which come to the anesthesiologist, most of the time, 90% of the time, it is Down syndrome, autistic spectrum disorders, metabolic disorders, and cerebral palsy. So they come for investigations, MRI investigations, CT, or for surgical procedures or examination under anesthesia. So what are these challenges? The staff lack the knowledge of the specific challenges faced by the families. They may not know what are the difficulties and what are the challenges which are routinely faced by the families in their day-to-day life while taking care of these patients. They are more used to our usual set of patients, which is not, this type of patients are not included in their curriculum. And you have to rely on the specific caregiver. Child will not, once the child is awake, or once in the pre-anesthesia time also, child will not be happy with any other person. And there are challenges in managing daily activities outside the home environment, like hygiene, etc. And children is unable to communicate distress in a way hospital staff can understand. it is always the mother best to express that child is having pain, child is about to vomit like that, or the child is having constipation like that, because they are attached to the child in 24/7. And sometimes we have to restrain the child in a bigger child, and you need adequate human resources. These are the usual social challenges. And come to the individual case scenarios. In Down syndrome, what are the anticipated anesthetic concerns? Child may be obese with the craniofacial anomalies. Atlanto-occipital instability is very common. Congenital heart disease are common. Epileptic, very often we have history of epilepsy, and the anesthetic implications are difficult airway, difficult venous access, airway obstruction, and post-intubation. I'm not going in detail to these conditions because that's not this is the overview of these, our anesthesia concerns. And what about autistic spectrum disorders? You have to think of the basic triad of impairment, that is difficulty with the social communication, difficulty with social interactions, and difficulty with social imagination. Child will be entirely an isolated human being. So they require the greatest flexibility in our approach or in our anesthetic technique. So what are the anticipated anesthetic concerns in autistic spectrum disorders? This group of patients is the most difficult to manage and the most challenging ones also. They are intolerant to unfamiliar environment, personal noise, bright light. They also always prefer, even the parents used to tell us, we have to give a cubicle in an isolation area. So they resist even change to hospital gown. Sometimes we may have to sedate the child, or we may have to give IM ketamine and sedate the child to change to hospital gown. And there will be always difficulty in communication with the child. Child is there in their own world, and difficult to get history, examine the patient, or taking blood samples for lab investigations, as in our case. And they may be quite often in polypharmacy. Patients may be on different anti-epileptic medications, antidepressants, sedatives, anxiolytics, even in some Ayurvedic medications also. So you have to know what are the medications the child is getting. And what are the pathologies most commonly associated with disabled children? Very often we get craniofacial anomalies as in Down syndrome, or collaboration difficulties like in autistic spectrum disorders, or intellectual impairment, or in phobia child, or motor dysfunction as in cerebral palsy, epilepsy, or neuromuscular disorders. So always consider that MR children, mentally retarded syndromic patients associated with cardiovascular, endocrine, and electrolyte imbalance, which is very common. So always have a suspicion of the associated anomalies in syndromic child. In Rett syndrome, which is a variant of autistic spectrum disorders, there could be intraoperative malignant hypothermia, and the risk is very high, and you have to be extremely careful about this type of children, though rare in our scenario. The higher incidence of extension difficulties of the head and micrognathia is very common, because we could not even examine the airway, or the external appearance of the child may not be, sometimes the child may not cooperate also. And in very select group of patients, you can even consider pre-medications from home, but you have to be very, very careful in selecting such group of patients. And you should have a reliable caregiver also. We have employed in few scenarios, at that time diazepam, midazolam tablets were available. We have given it from the home and asked instruct the mother to give it from home and bring the child. And the real challenge for anesthesiologists is outside operation theater procedures, especially for the MRI and CT. And avoid deproducing neuromuscular agents in case of muscular dystrophia. So you should have a flexible, holistic approach. You should be very considerate to the parents, to the child. You should be empathetic to them. And sometimes you have to coordinate the multiple specialties, because once the dental surgeon is finished, the urologist will post the case next week, which is very distressing for both the child, the parents, and for us also. So it's always better to have everything done in one sitting. And the parent or guardian can communicate with the anesthesiologist before admission. Even the child should not be there. Even the parent or guardian can come and discuss. They can come to the anesthesiologist and show the medical records and discuss with the anesthesiologist, so that we'll be prepared for the child's visit. And definitely you have to minimize the waiting time in the hospital as fast as possible. Possibly you have to fast track this child. It is for their comfort. Better to have a checklist specifically designed. In high volume centers, there are definite checklist which is for the for this group of patients, which is available in the net. This is one sample checklist. You have patients, carriers, carrier's name, contact phone number, and developmental level is also there. General health, mobility needs, communication needs, everything is there. What the child likes, dislikes about the activities, objects, food, and action taken also. So that is available in high volume centers. And what are the anesthetic strategies in differently abled child? Encourage to bring to the hospital any activity or sometimes toys which will calm the child. You may require it in the preoperative and the postoperative time. And there should be clear instruction to fasting guidelines that should be given to the caregiver. Sedative mixed with the clear fluids can be given in the preoperative area, or they can ask the parent to apply emblacrin from the home with occlusive dressings. And you can even try induction in presence of caregivers. And it is best to understand the functional levels of autism of the child, because there is a 1, 2, 3 different levels, and the severity of disease will be according to the function levels. In autism spectral level 1 requires support, but difficulty in initiating social interactions. But these children are better manageable, and sometimes they may even allow us for IV cannulation in the presence of caregivers. But level 2 and level 3 has different scenarios. They may not cooperate. They may even sometimes in level 3 require very substantial support. They're very difficult to communicate even for the caregivers, and always in great distress. And there are some hobbies or activities, as I mentioned, the child is used to it. There are different types of hobbies. You can ask the parents to bring all these toys to the hospital so that it will be help to calm the child immediately after surgery when the child is awake. And there are different examples of pre-medication drugs, but there is no different guidelines that one single drug is to be used. You can use a pre-medication which you are comfortable with. And I have given this. My personal preference is I used to go for dexmedetomidine nowadays. I apply it intranasal. I apply it at 2 microgram per kilogram body weight, and has to one disadvantage is I have to wait for 30 to 45 minutes. You get satisfactory sedation and good separation from the parents, and there is greater acceptance of face mask and reduce the agitation on awakening, but less postoperative nausea and vomiting, which is a great disadvantage. And postoperative shivering is also less, but you have to wait for a long time, like 30 to 45 minutes, and it is very good in pediatric daycare procedures because of short half-life, like 2 hours in children. But you have to be very careful about the bradycardia. And encourage the caregivers to be with the patient in the postoperative period. That has to be there. Otherwise, you may not get the cooperation of the child. Go by the usual augmentative and assisted communication methods the child is used to. I will show you what the usual augmentative and assisted communication devices are. And always ensure good analgesia and prophylactic antiemetic, because the child may not be able to communicate. You have to take into consideration that also. And plan for rapid, smooth recovery and early discharge. And IV cannula has to be removed as soon as possible, and don't have to wait for our usual set of protocols. And these are different kinds of augmentative and alternative communication devices like keyboards on ASA1, autistic spectrum disorder 1. They may use even pen and paper. Mobile devices is very common nowadays. Custom language and custom systems are there. Sign languages are there. Charts and imaginary charts are there like this. And this is very common nowadays with the ASD children. And consent is very important. It should be given by the relative irrespective of the age of the child. And there should be an informed consent in addition to our regular consent. And it should include detailed anesthesia plan, post-operative care plan as well, and instructions regarding fasting, regular medications, deviations from the regular care or pre-op workup should be there. Because sometimes we may not be, as in our scenario, we may not be able to take the blood samples or further investigations. We may have to take the child even without it. I will show the consent form which we take in our institution. This is our consent form. Usually we take in our vernacular language. There is English consent also for patients who are from outside Kerala. So these are the, you have to write what the procedure is. Do you need to know some risk or complications which includes, so which has to be explained to them. Patient specific risks should also be explained to them. And it has to be signed by the two persons, and in this case in the child patient or substitute decision maker, and it has to be signed by the senior consultant and with the date and preferably time. And post-operative analgesia, as I mentioned, is very, very important. Caregiver should always be present in the recovery room. He or she may be able to better point out that the child is getting some pain, and the expression of concerns of the child to pain is better understood by the caregiver. Unrelieved pain can exacerbate post-operative cognitive impairment, and child can easily go for agitation. The usual flag scale like face, leg, activity, crying, and consolability scale, and child facial coding systems have little evidence in use in disabled children or challenged children. And you need to have a non-communicating children's pain checklist, which is modified for this group of patients. This is the non-communicating children's pain checklist score, which can be adapted for the physically challenged children. Now, you always remember that this group of children has limited capacity to report the potential adverse effects of any pharmacological agents. So you need a one-to-one nursing care in the postoperative ICU, and any adverse events faced by their management and their management should be clearly documented and given to the caregivers for future reference, because some of the children may come for multiple surgical procedures in your own hospital or in some other hospital. So it will be useful for the second anesthesiologist, who is going to anesthetize the child. So to conclude, standard perioperative path is inapplicable. You have to individualize for each child and always involve the leading parent or caregiver. Without their help or without their active involvement, it is very difficult to understand the child, keep the child in the preoperative area or in the postoperative area. What is required is a calm, unhurried approach in the presence of a familiar person. Think of possible comorbidities while assessing the patient. You may not have full set of investigation as you wish to have. And pharmacological interaction between anesthetic and home therapy, that is very important, because I have seen many of the children come with Ayurvedic medications. We may not know what the interactions are, and the other anti-epileptic medications, antipsychotic drugs also. In case of doubt, you have to refer all these things. And anticipate difficulty in evaluating the child, because you may have to, the first time you will be evaluating the child's airway will be on the table sometimes. Recognize the signs that increase the stress of the child in the postoperative period, and the caregiver will be better suited to inform you all these things. find out the stress reducing activities of the child and ask the parents to bring it to the hospital. Anticipate on-table surgical decisions. Sometimes the child may be posted for examination under anesthesia and proceed. So you may have to anticipate on-table surgical decisions, and which has to be included in the consent also. And difficulty in mask ventilation and visualization of the glottis, you can always anticipate, and you have to be equipped to handle a potential difficult airway scenario, and always get the help of a senior consultant also. And you need post-op extended monitoring for pulmonary complications also. So thank you, my seniors, teachers, and friends, for the patient listening. And sometimes even the greatest joys bring challenge, and children with the special needs inspire a very, very special love. Thank you once again.
Dr. Rajesh, that was an excellent discourse on child with special needs coming for anesthesia and sedation.
Thank you, sir.
You really incited a lot of interest among the audience. There are some questions in the chat box. Dr. Muthukumar wants to know, can ketamine be given in low doses as less than 1 milligram per kg?
Definitely. We have given for agitated children to sedate them, to put the cannula, and I have given the whole list of sedative agents, which is recommended in the recent review. That was from, I don't remember.
I think South African Journal of Anesthesia.
Yeah, South African Journal of Anesthesia. It was there.
Yeah, they have given even a very higher dose of ketamine.
Yeah, 5 milligram, 5 to 10 milligram. Yeah, that's the, you can give that. Usually we require 5 to around that dose, 5 milligram minimum.
And he is asking again another question: how is post-op delirium managed in this group?
So it's very difficult to manage. The best option is to always bring the item which the child is comfortable with, and that has to be with the child in the extended postoperative period.
Yeah, that is interesting.
And sometimes we give it in a few cases to calm them, the patient children, we have given dexmedetomidine infusion also.
Yes, Dr. Rajesh, yes, I was about to say that dexmedetomidine is of a great help in post-op time, and also we have used smaller doses of propofol, but you need to be very careful while
About the airway.
Protecting the air and respiratory distress, because these children sometimes will be very, very sensitive to the sedative agents, which we may not be able to assess. Here I would like to draw your attention to children with the history of epilepsy. The lot of children with learning disabilities and intellectually challenged have history of epilepsy, and they will be on several medications for that. And what is your experience in this field when you sedate them for procedures?
Usually they come for the MRI and all. So usually they come with having the morning dose of all these anti-epileptic medications. So you have to be very careful when you say sedate this patient for MRI. You can only give titrated doses, incremental doses under your observation, and you need monitors also, because many of the MRI suits may not have any sort of monitors. You can sedate the child from outside, and then once the child is calm, bring it inside the MRI suit. You need at least a minimum pulse oximeter so that you can monitor the saturation and respiration, and you can observe the child from outside and see the respiratory movements.
Audience, please post your questions in the chat box. Okay, we can convey them to the speakers. So please don't keep quiet and have questions in your mind. Please express them in the chat box. One more thing I want to ask you, Dr. Rajesh, that these patients who are on antiepileptics are sometimes resistant to sedatives. This is what I found in my early practice, where I used to do a lot of sedation for imaging procedures, MRI and CT scans. In those days, MRI used to take a long time. Nowadays, MRIs are a bit quicker. what used to happen, many of these children never used to sleep with smaller doses of propofol or midazolam. Those days, dexmedetomidine was not yet available. And in certain cases, propofol used to unmask the convulsions. So there's one dangerous situation. We need to be very careful when we use propofol in these children for sedation. What is your experience in this field?
So we may use mostly dexmedetomidine and sometimes dexmedetomidine plus ketamine. So that combination I found is very useful. Dexmedetomidine plus ketamine.
Yes, it's a good combination. Yes. Sometimes the procedures are done for painful lesions. The imaging is done when the patient has a painful limb or something like that. Then it is very useful to have a smaller dose of ketamine, which gives a very good analgesia.
And the thing everybody has to remember is that these children should be fast-tracked, because when we go to MRI, they will say sometimes that we are in the waiting list. One patient has to, but these kind of patients, you have to be compassionate to them. We have to give consideration to the parents, the concerns of the parents, and to the child also. And you have to fast-track, give preference to this group of children, unless it's there is an dire emergency case pending in the MRI suite.
There's interesting thing, Dr. Rajesh, because fasting these children is difficult. Once they are hungry, to control them, sometimes it's difficult for the parents. They are very cranky or crying and unconsolable. So then you cannot wait for a long time and make the scene very noisy. Becomes uncomfortable for other patients who are waiting as well. There is
a question by Professor Vikram Vardhan. Any interaction with dexmedetomidine and with antidepressant or antipsychotic drugs? I'm not aware of these interactions, but any antidepressant or antipsychotic agent which can cause bradycardia can exacerbate with dexmedetomidine. That is my concern. Otherwise, I don't know. I am not aware of it. Usually, we discuss with the neurologist when your epileptic medications or any psychotic medications can have an interaction with these are the agents which we are using. But specifically with the dexmedetomidine and any antidepressant, I'm not aware of. But I am worried about exaggerated bradycardia, because that's something which we are worried about dexmedetomidine.
Yes. Sir, Valjit Singh, sir, do you want to add some points from your side? Okay, so
sir has to unmute.
Yes, sir, has to unmute. So if more questions are there, Dr. Rajesh will take in the end. There is one more case discussion by Dr.
Vijish
Venugopal, sorry. So after that, I think we can take a few more questions.
Okay, sir.
I think that should be all right. Now I welcome Dr. Vijish Venugopal to speak on a topic that is more interesting. It is a bronchoscopy in a kyphoscoliotic patient. It's a very interesting topic. Dr. Vijish Venugopal is principal of KMCT Medical College, and he is a professor of anesthesiology there. His areas of interest are very wide. That is cardiac anesthesia, ICU, quality and safety, and perioperative echocardiography. This is very interesting because people in anesthesia definitely should and must have an eye on quality and safety, because ours is one of the danger areas. It's aptly addressed by Dr. Vijish. And he has got many awards. Among them, some are COPS Award in pain category in ISOCON 2001, and he won gold medal in exit exam of PGDM of USA. He has got many publications in national and international journals. Now I welcome Dr. Vijish Venugopal. And before he starts, I request again the audience to post their queries on the chat box so that we can address them at the end of the session. If you have questions about Dr. Rajesh's topic also, you are very welcome to post them and we will have a discussion on it. Welcome, Dr. Vijish Venugopal.
Thank you, Sripada sir, for that kind introduction. And good evening, everyone. I'm audible, sir?
Yes, sir. You're audible and slides are visible.
Yeah, thank you, sir. So I'll be dealing with bronchoscopy in kyphoscoliosis. What I'm planning to do is we'll take up 3 case scenarios first, and then we'll discuss regarding them. So the first case scenario is regarding a 76-year-old woman who had gross congenital kyphoscoliosis and copulmonary leading to type 2 respiratory failure. The patient required assisted non-invasive mechanical support in the form of nasal BiPAP. Recurrent bouts of respiratory infection necessitated admission to the hospital on a nearly bi-monthly basis. On examination, she was poorly nourished but comprehending and had a prominent kyphoscoliosis. There was auscultatory and radiologic evidence of collapse of the lower and middle lobes of the right lung, and bronchoscopic appearance revealed complete obstruction of the intermediate bronchus just after the takeoff of the right upper lobe. Apart from evidence of infected purulent retained secretions and associated inflammatory changes, the bronchial mucosa was undisturbed. So this is how her X-ray looked, with collapse of the right lower lobe and the middle lobe. And this bronchoscopic view shows the collapsed intermediate bronchus on the right side. I'll just show you a video of this patient's CT. So the video is visible, right? You can see in the CT, there is the kyphoscoliotic change is seen, and you can see the
video is not playing.
Yeah, and you can see that the left bronchus is quite normal, while the right mainstem bronchus itself is showing some amount of compression. And you can see some atelectatic changes in the right lower lobe.
Dr. Vijish, the video is not playing.
Not playing?
Playing.
It's not playing, right?
Not playing.
Yes, sir. It is not playing.
Oh my God. Okay. I'm really sorry about that. So the just CT shows that there is a compression. I'll just explain that. The CT is showing compression of the right lower lobe bronchus. And what about this video regarding the bronchoscopic view? Is it playing?
No, sir, it's not playing. You can go to the file, original file, and you can play that and share that screen also. No, that is also we can do.
I mean, so when there's nothing specific in that, I can show the kids. It's fine.
Okay. Okay. All right.
So what it is showing, the bronchoscopy is showing that there is a slit-like opening of the intermediate bronchus on the right side. And what they did was they put in 2 expandable endobronchial metal stents, and the patient was extubated the next day with the chest radiograph showing expansion of the middle and lower lobes, as well as the patient's FEV1 and FVC also improved up to 125%. So this is the first case. And this is the post-op X-ray. You can see that the patient's right lower lobe as well as the middle lobe has expanded when compared to the pre-op X-ray. In the case scenario 2, it's an 85-year-old woman who presented to the emergency department with fractured neck of humerus, and she had a history of severe osteoporosis and was being treated for that. Physical examination revealed marked kyphosis with a 90-degree forward curvature of the thoracic spine. Following treatment for her humeral fracture with a collar and cuff, she developed stridor and then a respiratory arrest requiring resuscitation and non-invasive positive pressure ventilation. On further questioning, the patient described previous episodes of these attacks of stridor, which were not related to any specific triggers and resolved spontaneously. The initial investigation, it revealed that there was an extrinsic compression of the mid-trachea with lumen narrow to less than 5 millimeters, and there was pulsation in the anterior wall of the trachea. And a spiral CT scan which was performed with the patient in the lateral decubitus position had severe kyphosis. And with the aid of a three-dimensional reconstruction, forward deviation of the trachea was seen. And also the brachiocephalic artery was compressing on the airway. So this is the reconstructed spiral CT image where you can see the extrinsic tracheal compression. And the sagittal view also shows the same here. So this patient also was a kyphoscoliotic patient who also underwent insertion of tracheobronchial stent, and postoperatively when the spiral CT was taken, the compression was relieved, and you can see this tracheal stent in situ. So this is the second scenario. Now coming to the third scenario, here there's a 72-year-old patient with severe kyphoscoliosis presenting for urgent laparotomy, and on doing a direct laryngoscopy, it was seen that she had reasonable laryngeal views, and but intubating the trachea proved challenging. The tracheal inlet was visible, and they passed the 8 mm endotracheal tube through the cords, but they were unable to further advance it beyond the cords. They tried to pass a gum elastic bougie, and they even tried multiple times with smaller caliber endotracheal tubes, and this was unsuccessful. And a senior colleague then did a further attempt, and a 6 mm tube was passed through the cords, and the cuff was inflated just below the vocal cords to temporarily secure the airway. But they found that the intermittent positive pressure ventilation was necessitated very high airway pressures. And they passed in a flexible scope, and they noted that there was some abnormality in the distal lumen of the trachea. And this is how it looked. This is the sagittal view. You can see this here. You can see that the trachea has moving posteriorly and to the right, and there is compression from the right brachiocephalic artery. And how did they manage this case? They passed in an ultra flexible tip guide wire from an ARNT airway exchange catheter, and then passed a microlaryngeal tube, a 5 mm microlaryngeal tube, and then did the case. So what all these three scenarios show us is that in patient with kyphoscoliosis, there is a significant amount of airway related changes within the trachea. So how do we approach these patients? We have certain patient related risk factors, comorbidities related risk factors, and procedure related risk factors. Now coming to the patient related risk factors, most of these patients in the three scenarios that I showed were elderly, and also they had a component of frailty. Coming to the comorbidities are that these patients all had severe kyphoscoliosis, as well as they had respiratory failure which required non-invasive ventilation. Now coming to the procedure related risk factors, it depends on whether the patient is going to undergo a fiber optic bronchoscopy or a rigid bronchoscopy. So now coming to the patient related risk factors, that is, most of these patients are geriatric patients, and these geriatric patients are all vulnerable because they have limited response to hypovolemia, hypotension, or hypoxia. Their response is limited to these conditions, and the lung compliance in elderly is decreased. The arterial oxygen tension is decreased. They have an impaired cough reflex. There is increased susceptibility to hypothermia, and the excretory function is limited. So all these patients have to undergo a comprehensive geriatric assessment. And a comprehensive geriatric assessment is a multidisciplinary teamwork where the medical, environmental, social, psychological, as well as the functional aspects of the patient is taken into consideration. Now, medical aspect is most of these patients are on polypharmacy and they have many comorbid conditions. Their nutritional status will be very poor. Now, regarding their mental health, their cognition and their fears have to be taken care of. Similarly, their functional capacity should be looked into, as well as their social circumstances and the environment. So there is a proper assessment that has been done, and a stratified problem list has to be prepared, and a bespoke management plan with goals have to be identified. So we ideally have to have a perioperative frailty team with comprising of the ward nursing staff, the anesthesiologist, the surgeon, the geriatrician, as well as a social worker. And it was seen that once this CGA was implemented in elderly people, especially with frailty, they found that there was reduced postoperative complications in elderly surgical patients. So the anesthetic concerns, especially the pre-operative concerns for in an elderly, are that we have a lot of medical comorbidities. So especially the cardiovascular comorbidities are the most commonest, and there is confusion in these patients. So dementia and delirium could be a problem, and communication difficulties could be there. These patients are on polypharmacy, so you could have medication side effects as well as drug interactions. Then coming to the consent, the capacity to consent. They may need a consent form for adults who lack the capacity to consent to an investigation or treatment. Coming to the intraoperative issues, we could have issues with fluid balance as well as with maintenance of temperature. And postoperative care, we should make sure that the nutrition as well as pressure ulcers are not formed because of the reduced mobility and impaired swallowing. Now, it's very important that we know this American Geriatric Society Beers criteria, where they have found out a group of drugs which are potentially inappropriate medication in elderly individuals, where the potential benefits outweigh the potential risks outweigh the expected benefits. And very recently, we have an updated list of drugs which should be avoided in the elderly. And this is a very exhaustive list. And mainly it is the promethazine, diphenhydramine, the benzodiazepines, the meperidine, and metoclopramide. And drug-drug interactions which we should avoid are opioids, gabapentinoids, opioids, along with benzodiazepines and the anticholinergics. Now, this is an important diagram which shows that we should prevent certain things in elderly. We should give them optimum positioning to avoid peripheral nerve injury, pressure damage. The anesthetic technique, we should prevent. They are very sensitive to the overdose of anesthetic agents, so we should use depth of anesthesia monitoring in these individuals, avoid hypothermia, and maintain a restrictive fluid therapy and avoid anemia. Another very important thing is delirium. Now, delirium should be prevented. So, because prevention is better than cure, and we should take all possible actions like stimulating the mind, early mobility. We do have a bundle, that is the ABCDE bundle for delirium prevention. That is the awake and breathing coordination, choosing light sedation by avoiding benzodiazepines, considering dexmedetomidine, delirium monitoring and management, rutinary delirium screening, and focus on non-pharmacologic treatment, early mobility and exercise that reduces delirium. So these are the ABCDE delirium prevention bundle. So always remember the 4 M's of age-friendly care. Remember what matters. Especially these patients should be given their hearing aids and eyeglasses as soon as possible perioperatively to help them reorient and prevent delirium. Have a family member to visit to identify cognitive disturbance, preserve and motivate mobility, optimize the medications. So avoid medications in the Beers criteria, and assess and promote mentation. So always have a pre-surgery cognitive test to assess mental function for a baseline comparison. So these are the 4 M's that we should always remember when an elderly is being taken up. So the best practices, again, the consensus statement is that any patient over 65 get a pre-operative cognitive screening. And intraoperatively, we should avoid centrally acting anticholinergics, benzodiazepines, meperidine, avoid relative hypotension, maintain normothermia, and monitor age-adjusted end-tidal MAC fraction, and use EEG-based intraoperative brain monitoring to titrate anesthetic administration. A few examples of drugs which we should avoid, I have already mentioned that previously. And so that is regarding the elderly situation. Now, coming to the second thing, that was these patients had kyphoscoliosis. Now, severe kyphoscoliosis is associated with respiratory complications, often leading to respiratory failure. Superinfection and muscle weakness also influence the respiratory function. So the morphologic features of the trachea and bronchial tree in severe kyphoscoliosis have led to difficult intubation with endotracheal tubes, and intubation is often a requirement in these patients when they come with respiratory failure. Now, if you look at kyphoscoliosis, because of the reduced compliance, there is increased work of breathing. Because of the muscle weakness, these patients tend to develop respiratory failure, and the reduced lung volume causes hypoxia, leading to hypoxic pulmonary vasoconstriction, pulmonary hypertension leading to right ventricular hypertrophy, and RV failure. Now, extrinsic compression of the tracheobronchial tree from the spine and chest wall deformities are noted. The airway narrowing is often noted on chest CT and is confirmed with bronchoscopy. In cases of severe kyphoscoliosis, direct compression by the deviated thoracic spine or rotation and distortion of the airway can be seen. Now, this could be because of three mechanisms. Now, the trachea could be compressed either directly between the sternum and the vertebral body by the right brachiocephalic artery crossing the trachea, or by the vertebral body splaying the lower trachea at the carinum. This is a picture showing the slit-like opening in the bronchus. Now, how this has happened is because of the compression. This is a CT reconstructed image where the green one is the trachea and the blue one is the pulmonary artery. And you can see here, because there is compression, direct compression on the bronchus intermedius, which gets sandwiched between the spine and the right pulmonary artery. Now, how do you determine the severity of kyphoscoliosis? It is again based on the Cobb's angle. You have to find the terminal vertebrae and draw a line along the end plate, and where it meets is the Cobb's angle. In some cases, it doesn't meet. So, as shown here, you can see that you can draw along the end plate. You determine the terminal vertebrae and draw the line, and then draw a perpendicular, and the intersection of the perpendicular will give you the Cobb's angle. Any angle that is more than 10 is noted as scoliosis, and anything less than 20 is benign, and we should monitor these patients by X-ray every 4 months, and no surgery is required. But once this angle is more than 40 degrees, cardiorespiratory impairment is present and restrictive lung disease starts to develop. And if it's more than 100, you have severe cardiorespiratory involvement and severe impairment of gaseous exchange. Now, the severity or the angle of scoliosis was neither a good predictor for the site nor for the side of torsion. There are certain syndromes which are associated with kyphoscoliosis, like the Vater anomaly, the von Recklinghausen's neurofibromatosis, Marfan syndrome, rheumatoid arthritis, and Ehlers-Danlos syndrome. The anesthetic considerations, especially for a patient with kyphoscoliosis coming for a bronchoscopy, are difficult airway, the restrictive lung defect, which causes an increased risk of postoperative respiratory insufficiency, retention of secretions, postoperative respiratory failure, right ventricular failure, and pulmonary hypertension postoperatively. And also there is an increased risk of malignant hyperthermia due to the muscular issues. The next issue that our patient had was respiratory failure, and the patient was on BiPAP. And the moment you remove the BiPAP, he had desaturation and hypercarbia developing. So we need to have proper broncho mask. So we can do bronchoscopy if you have this bronchoscopy NIV mask. Either it can be done through the mouth or through the nasal pathway, depending on the mask on the site from where. If you're inserting it from below, you can do a nasal bronchoscopy, and if it is from the top port, you can do a oral insertion. And next is the procedure related issues. So we have to decide whether we are going in for a fiber optic bronchoscopy or a rigid bronchoscopy. And for a rigid bronchoscope, again, it depends, the anesthetic technique varies, or the ventilation technique varies depending on the type of bronchoscope that is used. It could be a ventilating bronchoscope or a Venturi bronchoscope. So now, how do you assess these patients preoperatively, those who are coming in for a bronchoscopy? The preoperative investigation should include the routine investigations like a hemogram, along with a coagulation profile in patients who are taking anticoagulants. Pulmonary function tests are done if there is a clinical suspicion of severe respiratory obstruction, and CT if the patient has hemoptysis. So mostly these patients would have undergone these tests before they come in for a bronchoscopy. And a pre-procedural blood gas is recommended in some patients, especially if your patient is on an IV, for evaluating the baseline status of the patient in terms of hypoxemia and hypercarbia. Now, special attention should be paid to oral cavity, the jaw, and neck mobility. Patients who are already dyspneic and require supportive oxygen, or who are hemodynamically unstable and hypercarbic at rest, they are at very increased risk of both intraoperative as well as postoperative complications. An important factor that you should keep in mind are whether the patient has an unstable cervical spine, whether there is decreased movement of cervical spine, especially in rheumatoid patients. There is rheumatoid arthritis is a association along with kyphoscoliosis, and whether the patient has limited mouth opening and laryngeal stenosis or obstruction. So it's very important you know this, because if the patient has to undergo a rigid bronchoscopy, he has to be put in a shaving chin position, which leads to extension of the cervical spine. Similarly, we should look for the time of the last meal, which should be established to assess the risk of aspiration, and the airway patency also should be assessed. Pre-medication, anti-sialogogues can be given. Injection glycopyrrolate can be given before the procedure, and it helps in drying up the secretions. But again, it's controversial. However, I feel that it will be good if you give it so that the local anesthetic that you give can act properly, and the secretions also will be minimal. Benzodiazepines, for example, injection midazolam intravenously can be given as an anti-anxiety drug in select group of patients, and it preferably should be avoided in elderly individuals. Bronchodilators of some people prefer to give bronchodilators before, give a nebulizing shot of bronchodilators before taking up for bronchoscopy to reduce the airway irritation. But however, randomized placebo-controlled trial has shown that there is no benefit of using this prior to bronchoscopy in patients with COPD. Now, how do you position these patients, especially for a rigid bronchoscopy? The patient is usually kept supine position at the edge of the table, and the head is extended by keeping a sandbag or shoulder roll. The head is placed on a ring with the chin pointing upward. This is called the shaving chin position. Intraoperative monitoring, standard monitoring based on the Helsinki Declaration on patient safety should be followed. This includes the ECG, the pulse oximetry, as well as the non-invasive blood pressure monitoring, and also the temperature monitoring. End-tidal carbon dioxide monitoring is usually not done. Now, coming to the ventilation strategies in rigid bronchoscopy, again, as I said, it depends upon the bronchoscope type that is used. If you have, it could be either apneic oxygenation, or it could be spontaneous assisted ventilation, or if you have a ventilating bronchoscope, you can use controlled ventilation, as shown here. The anesthetic circuit can be connected to one of the ports, and the elastic caps can be put on the telescope. And if you have a Venturi bronchoscope, the Venturi bronchoscope here, then you can use either manual jet ventilation using a Sanders jet injector, or a high frequency jet ventilation can be connected on this port. And this is a Venturi bronchoscope where the air gets entrained and the patient gets ventilated. The anesthetic considerations for rigid bronchoscopy: ideal anesthesia requires hypnosis, analgesia, and muscle relaxation. Balanced anesthesia is usually the technique opted for rigid bronchoscopy. You can induce anesthesia with propofol, etomidate, or ketamine, depending upon the patient's hemodynamic status, along with a dose of fentanyl in adults and inhalation agents in children. Fentanyl boluses and short-acting can be used in small doses to avoid the pressor response. Now, the vocal cords should be sprayed with 4% lignocaine to prevent postoperative laryngospasm, and anesthesia can be maintained with dexmedetomidine or intravenous infusion of propofol. Use of short-acting muscle relaxants is recommended. TIVA can also be used. Deep sedation with spontaneous breathing has also been used instead of general anesthesia, but the issue is hypoventilation and laryngospasm may occur. At the end of the procedure, reversal of the neuromuscular block is done with neostigmine and glycopyrrolate. The complete reversal of the block is essential because a lot of these patients lack the respiratory reserve to tolerate any residual block. Now, it's extremely difficult to place these patients on the bed because of the kyphoscoliotic hump, and so we can put them in the lateral position. and it's little challenging, especially with the rigid bronchoscopy. Now, for flexible bronchoscopy, you should have a proper topical anesthesia that is done along with sedation. And just going with the innervation of the airway, it is both the vagus nerve as well as the glossopharyngeal nerve, which supplies the sensory part. The superior laryngeal nerve, the internal branch, supplies the sensory part above the cords, and the recurrent laryngeal nerve provides the sensation below the vocal cords. And the glossopharyngeal nerve is sensory for the vallecular and base of the tongue. So these are the branches which you have to block. Excuse me. And you should have, these are the things that you require. You should have a lidocaine gel, a 10% lidocaine spray, a 4% lidocaine solution, and a syringe for intratracheal application, along with a 22 gauge needle for giving transtracheal insufflation. And here you can see this patient, the patient is being nebulized with 4% lignocaine, and this is a McKinsey technique where a 20 gauge cannula is connected to a 3-way, and the other end of the syringe is connected to the oxygen insufflation port. So if you don't have a mucosal atomizer device, you can prepare one using the McKinsey technique. So one technique that we can use to anesthetize the airway is you position the patient on the trolley for administration of local anesthetic, followed by a semi-recumbent or supine position, depending on the patient operator's preference and the patient's convenience. This is because of the kyphoscoliotic hump the patient might have to be put on lateral position. You identify the patient's most patent nasal passage, spray the nasal mucosa with a vasoconstrictor, nebulize 4 ml of 4% lignocaine. So just I'm giving you some calculations here. So that is around 80 milligram, of which 25% will be typically absorbed. So that is around 20 milligram. Then coming to the nose and nasopharynx, that it should be anesthetized by using you can soak a cotton bud or the cotton applicators, or a ribbon gauze can be soaked in the local anesthetic, and it can be packed into the nose and the nasopharynx. You can use either lignocaine 2% with adrenaline, or you can use 4% lignocaine with 1 in 2 lakh adrenaline. So if it is 2%, you can use 5 ml and the other one 3 ml. So this around comes to around 100 milligrams. And on the tongue and the oropharynx, you can put 4 puffs of 10% lignocaine to the throat, 2 each side on the tonsillar pillars and back of the throat. So that comes to around 40 milligrams. And the pharynx and the larynx above the cords can be anesthetized again by the metered spray, or you can soak the swabs at increasing depth using a spatula, or you can put the jelly on the laryngoscope and then slowly paste it along the tongue. You can also use 4 puffs of 10% lignocaine to the nose and the postnasal space. That again comes to around 40. So far we have now used 225 milligrams of lignocaine. So the maximum total dose that is allowed for topical anesthesia of the airway is up to 9 milligram. But for a bronchoscopy, you can use a lesser dose of up to around 7 milligrams per kilogram. For 9 milligram, this is probably for doing a intubation process. And you can allocate the remaining dose depending upon the weight of the patient in 1 ml aliquots to anesthetize the larynx below the cords and the tracheobronchial tree. You can either use the SAGO technique, or you can give the cricothyroid or the transtracheal injection. So the SAGO technique, you can use an epidural catheter through the working channel, and the epidural catheter can come out of the working channel around a centimeter of it, and then you can drip 1 ml of 4% on the vocal cords, below the vocal cords, and along the trachea, including to the carina. So that is the SAGO technique. So then there are a lot of other authors have given their techniques, where in the nose they spray cophenylcaine spray, that is a combination of 5% lignocaine with 0.5% phenylephrine, and they give some amount of sedation during this time. And in the pharynx, they give a 10 milligram per spray lignocaine to the tip of the tongue and 6 sprays to the superior pharynx and 6 sprays to the inferior pharynx, and the Sego technique for anesthetizing the larynx, 2 ml of 2% lignocaine above the cords and 2 ml of 2% lignocaine below the cords. And during these injections, the patient is advised to take deep breaths. And different techniques are available as per your expertise and your experience. You can use different techniques, but make sure that you don't exceed the total dose. So in summary, with severe kyphoscoliosis, the chest wall and spine deformity can occasionally lead to torsion of the central airways. This can be sufficiently severe to be manifested as complete obstruction. So patients with kyphoscoliosis who present with progressive deterioration respiratory function with evidence of obstructive airway disease, they should be considered for bronchoscopic examination. But we should be very careful in positioning these patients because of the kyphoscoliotic hump. They would not be able to lie down supine, and we should preferably put them in the lateral position. And we should also make use of the virtual bronchoscopy, which is a CT, a novel technique using the multi-detector CT images. And this may demonstrate endobronchial lesion, stenosis at the previous site of tracheostomy or bronchial torsion. Radiologic and clinical evidence of collapse or airway trapping will support the diagnosis. The use of FOB to rule out airway abnormalities prior to insertion of a rigid bronchoscope in kyphoscoliotic patients will go a long way in planning your procedure. Thank you very much.
Thanks, Dr. Vijish. That was an excellent discussion about tracheobronchial distortions in kyphoscoliosis association. Very interesting it was. You brought out multiple aspects of this problem. It was very interesting. Usually this kyphoscoliosis is associated with restrictive lung disease. Therefore, the patients may have a lot of respiratory insufficiency, and at the same time, they may have difficulty in positioning. In that case, how to overcome the situation, Dr. Vijish?
We will have to, we can position them in the lateral decubitus position, and preferably we will do these rigid, especially if the patient requires for a tracheal stent to be placed. All the other procedures can be done using a fiber optic bronchoscopy. So I think preferably we should prefer for a fiber optic bronchoscope.
I think along with that, we can add CPAP or HFNC to maintain the oxygenation of the patient and reduce the work of breathing as we go.
Yeah, we have special NIV bronchoscopes through which there are openings for passing the fiber optic bronchoscope.
Yes. So that will solve one side of the problem. Other side is positioning. We need to be really careful because we witnessed a case of severe kyphoscoliosis who had subluxation of cervical spine, and it had to be fixed. What happened after intubation, which was very difficult, and it was pre-fiber optic intubation days in the peripheries. It was very difficult. However, we could manage. But the surgeon was very enthusiastic in getting the patient positioned appropriately, because flexed neck is no good for them to fix. Unfortunately, what happened, it was a very friable spine and there was a fracture. And the outcome was not good at all in the end. This point has to be taken note always when we position the patient. With adequate pillows and cushioning, I think we have to conform our mattress to the shape of the spine of the patient.
Correct, sir.
And in between, Dr. Rajesh, you have a query from Dr. Vikram that he says how to instill dexmedetomidine spray in a uncooperative child. Dr. Rajesh? I think Dr. Rajesh had some network issues. Anyway, he has already answered this in the chat box, which audience may not be able to see. He said they use insulin syringe for taking the drug and hand over to mother or caregiver for installation. They will take time and install once the child is distracted by the activities. There are atomizers devices also. Yes, atomizer devices are available. I think one of the manufacturer is Teleflex, who sells these disposable atomizers. Once we can take the adequate dose of drug in a small syringe, say 2 cc or 1 cc, you can fix the atomizer to the tip of the syringe and you can spray the nostril. If the parent knows or parent or caregiver knows how to use this device, it is not difficult to instill the medication. However, a word of caution is that the preparations what we use, they are not for nasal instillation. So there may be some singeing sensation in the nose, stinging sensation. So the child may not really like it. I welcome back Dr. Rajesh.
Hello? Hello?
Yes, Dr. Rajesh.
Yeah, what happened was there was a power failure, unfortunately. But so there was a question regarding how will you install dexmedetomidine in an agitated child?
Yes, that I was explaining that because you were not able. So
what we do is we take the drug in an insulin syringe, remove the needle and hand over to the mother. Once the child is agitated, we'll install the drug, or sometimes we ourselves may be able to install. And there are atomizer devices also, by which you can dilute dexmedetomidine in saline and install. And in a very agitated child, this technique won't work. You have to go by IM ketamine.
Yeah, there's a question by Dr. Muthukumar to Dr. Vijish. Why do you use 4% and not 2% lignocaine for airway anesthesia?
Well, this 4% is used mainly for nebulization purpose, and actually there are some trials which have compared 4% and 2%, but none of them have conclusively showed that 4% is better than 2%. And they have the conclusion was that we need larger trials to say that which is better.
Yes.
But for nebulization, it is the 4% is the one which is preferred. But if you see in both the things that I have shown, it's personal preference probably, and according to the availability you can use.
And to note, American guidelines have revised the total dose of lignocaine admissible to nebulization to 9 milligram per kg body weight. So still we can, I think, use 4% lignocaine. And 4% lignocaine advantage is has got it, if it gets dispersed in mucosal barrier, the effectiveness does not decrease because of the concentration. And also the nebulization procedure is shorter compared to 2% because you take lesser volume for nebulization. Yeah. And one more query to Dr. Vijish. How do you pre-medicate these patients with elderly kyphoscoliosis and airway problems? Because elderly patients are known to have a lot of anxiety, and hypertensive IST patients are there.
Definitely, it's a big challenge because as per the Beers criteria, we cannot use any anticholinergic. We cannot use benzodiazepines. So it's a bit of a challenge in taking up these patients, pre-medicating them. But we definitely do give a dose of glycopyrrolate, however, and for reducing the anxiety, in our institution, we do give a small dose of midazolam and of course fentanyl too, 25 microgram. And all these drugs in my talk I have told should not be given to the elderly people.
Actually, to add to that, Dr. Vijish, we do use smaller doses of alprazolam, because alprazolam rarely causes so much of depression, but it is a good anxiolytic. What we found is say 0.25 milligrams of alprazolam can really calm down the patient and they can have good sleep overnight, but they'll be fresh in the morning and it's less likely to cause respiratory depression of whatever sort. Anything you want to add, Dr. Rajesh?
So any queries, because my this chat box, the past questions are raised.
I
Any
think
questions concerning my topic?
I think the questions were that many we are expecting more questions from the audience. Meantime, there was a program list from Indian College of Anesthesiologists. I think audience went through it. We can display it again. Jayashree Madam, do you have any more suggestions or comments on the topics we discussed? Welcome to the discussion.
Good evening, Dr. Sripada. Thank you so much. And it was really a pleasure listening to the webinars. The topics were so well chosen. And very interestingly, Dr. Rajesh was asked to speak on the differently abled children as a perioperative concerns, and he covered it so well because pediatric is a very special population, and truly to say that any anesthesiologist can give anesthesia to a child or especially a baby is not correct. And we are very particular that we have a group of consultants who deal with this. Of course, a little older children, we allow anybody, but definitely this group, and especially the different abled, are a special category. And Dr. Rajesh, of course, discussed so well the newer drugs, because many of us still don't know how to use dexmedetomidine, how to pre-medicate these children, and especially the differently abled children, of course, are very special. So that was very well explained by Dr.
Thank you,
Rajesh.
madam. Thank you, madam. Thank you, madam.
Rajesh, I'll just like to ask you, what is your choice of the pre-medication? Because of course, these are differently abled, I know, but otherwise in your hospital, what is your protocol for the children who come, supposing for a daycare procedure?
So, madam, we routinely give nowadays this thing, dexmedetomidine transnasal only. Only problem is that it takes a longer time to act. You have to wait for sometimes 45 minutes, 32, minimum 30 minutes, but 45 minutes. Even though textbook recommendation is 1 to 4 microgram per kilogram body weight, we go by 2 microgram minimum, and sometimes even top-up doses may be required.
Okay, so you've completely changed over, switched to dexmedetomidine, is it?
Yeah, nowadays because we get a lot of pediatric patient for daycare tonsillectomy, adenoid.
Yes. That's true. Dexmed has its own advantages. What about the earlier that we would probably giving these children some this alprazolam or anything like that?
So previously we had this thing, midazolam syrup. That was I found midazolam syrup was very good. Now we don't have a midazolam syrup preparation. But we have to use this the usual midazolam mixed with any clear fluids and give the child. I don't know and how palatable.
We just mix it with a little sweetening agent. And then give it sublingually. That's right. But of course, that also takes a minimum of 20 minutes.
Minimum time is that.
That's true. But truly, except for these children, you're using ketamine, of course, who are really very troublesome. But otherwise, how much ketamine do you use in your practice as induction or pre-medication?
For madam, this agitated children, we have to give minimum 5 milligram per kilogram body weight IM.
Yes. But otherwise, other children, supposing, then ketamine is surely not an option.
And then for a cooperative children, ketamine is not usually is not my an option.
Very true.
Because if I can put an IV cannula, if the child cooperates for me in an IV cannula, I will give a small dose of midazolam. And my pre-anesthesia workroom is just close to one door next to my OT, so that I can give some small dose of fentanyl, wait for some time, and take the child inside.
Very true, very true. So it all varies. That's why we need a pediatric anesthesiologist to manage these children. Yes, so true. Thank you so much, Rajesh ji. And Dr. Venugopal, of course, was given a very difficult topic, which he discussed so well. Bronchoscopy in three things. It was bronchoscopy was a challenging case in elderly patients and those with kyphoscoliosis. So truly that was a very, very challenging case discussion. And talking
Madam,
about,
there is a question for Dr. Vijish from Dr. Muthukumar.
yes,
Whether dexmedetomidine can be used in elderly kyphoscoliosis patients.
Definitely, we can use dexmedetomidine.
okay.
And how much
Yes.
can you use? Like a regular dose?
We
Because
usually give an infusion of dexmedetomidine. Usually, we usually omit the bolus dose,
Loading dose.
the loading dose.
Yeah. Are there any concerns of bradycardia in them in the elderly?
Yeah, especially the loading dose definitely can cause bradycardia in the elderly population.
Yes. Right. So you're giving it.
and often these
In-
patients may be on beta blockers, Dr. Vijish. So how do you manage that, or you just omit these drugs in case of beta blockers?
Yeah, if the heart rate to start off is initially low, definitely we should think about not using them.
Yeah. Yeah. Very true. Very true. And Dr. Venugopal, so you so nicely demonstrated all the different methods of bronchoscopy, which are so critical, and you showed all the options. So that was very, very nice. And of course, the elderly, in which nowadays the frailty is catching so much of importance. Initially, a couple of years ago, we really didn't talk about this much, although we knew about it, but still. But now frailty is so important and is always
It's
taken.
now referred to as the elephant in the room. It's seen,
Yes.
but it is ignored.
Very true, very true. So thank you so much. That was great. Dr.
Thank you, ma'am.
Sripada, that is all I would like to comment upon. And of course, thanks a lot. Yes. Any other questions in the chat box?
So for none. Thank you, madam. Thanks a lot for giving your valuable insights because
Thank you, madam, for the comments. Thank you so much.
Ah,
madam.
sincerity definitely matters in the experience using insights.
absolutely. So may I officially thank you all, Dr. Sripad, Dr. Rajesh and Dr. Venugopal for having accepted our invitation. You are all, of course, very, very important members of the Indian College, and we always strive for academic excellence. Thank you so much. And
Thank you, madam.
Thank you, ma'am.
Thank you.
so thank you, Dr. Radhakrishnan, Dr. Sanish, Dr. Vineet, and Dr. Baljit was also there, and we'll be seeing all of you and attending more, requesting you to present more webinars for the students. I think this goes a long way for the postgraduate students, the way today's discussion was, taken ahead. So thanks a lot and see you all next week. Thank you so much. The program was already highlighted in the middle. Thank you and good night.
Good night, madam. Good night.
Thank you so much, everyone.
Thank you, dear. Thank you, Rupsha. Sorry, I should have thanked you as well, Rupsa.
No issue,
Thanks
ma'am.
a lot. Thank you.
Thank you
Thank
so
you,
much,
Vineet.
everyone.
Thank you, ma'am. Yeah. Good night, ma'am.
Thanks, Vineet.
Good night.
That's very good.
Thank you.
Good night,
Excellent.
ma'am.
Bye-bye.
Good
Good
night.
night. Good night.
Okay, so with all your permission, I'm signing off here. Thank you.
Thank you.
Good night.
Good night.
Thank you, everyone. Yeah. Mm. 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 Mm.